Hi, everyone. Welcome. As we're waiting just a few minutes for everyone to come in, why don't you put in the chat, tell us where you are and what your temperature is tonight? Uh, Laura and I are in the Tampa Bay area, and we've had incredibly cold weather the last 10 days. It's been in the 30s and low 40s in Florida. So in Michigan, Amelia says it's 19 degrees, maybe. Michelle says it's in the 40s, which isn't too bad, Michelle. Uh, Chelsea, okay, Quebec, it's kind of warm, -8 today. Oh, that's centigrade. That's centigrade. So still cold. Brian in California. Oh, no, you're in Chicago, Brian. As is Bill and Debbie. And let's see, what
Yeah,
did you say it was, Brian? Um, 22.
yeah.
Whoa.
Jeff has 51 in Denver, which is warm. Stephanie has 18 in Chicago. Kristen, 55 in Boise. And Lisa, 56 in Seattle. Cleveland's 13, gonna be 4 in the morning.
Ugh.
Andrew says it's now 65 in Miami. Jenica says 71 in Arizona. Tim's 44 in Colorado. Brenda's 23 in New Hampshire.
Whoa.
Karen, hey, Karen is 58 in Port Charlotte, South Florida. 17 in Massachusetts, 52 in West Texas. All right. Bill,
Yes, I'm here.
welcome.
Thank you. Happy to be here, Whit.
We are so excited. I mean, so excited to have you join us tonight. We've been trying to do this, y'all, for about a year. We've had complications, including
Yeah.
one time Bill couldn't get on the internet in Hendersonville, North Carolina. Something glitched, and now they've been having ice storms there. So he escaped wintry North Carolina and went to Chicago. So now he's in warm Chicago with internet, where it's 18 or so. But Bill Hang is a superhero to all of us and his wife Debbie for the leadership that they've provided over 40 years now in making changes in dentistry that no one else had done. This is one of those deals where, you go speak at a meeting and they literally throw tomatoes at you because you're disagreeing with the usual and customary and you're talking about things that are absolutely truth. And Bill's been willing to do that in orthodontics as he realized many years ago, as he'll share with you, that he understood it's not good to start retracting everything because you're diminishing airway and breathing and tongue space and so many problems that come about. And so we've asked Bill to come on tonight and just not give us a history, but sort of give us an update on what he's seen happen through the years and where he sees things going. So Bill is going to talk to us about dentistry's new role in the future of optimizing health span. So Bill, take it away if you would, and
Okay.
thank you again so much for
Okay.
being with us.
Well, thank you very much, Whit. It's an honor to do that. You have a great organization. You've done so much for the profession as well. Uh,
Thanks.
I want to try to cover a lot of ground here with the reason to be concerned and the fact, it's really interesting because here's a slide that says health span. That was never something that I'd seen in dentistry at all, and yet it's really true. I'll go to the next slide here. In reality, what we're doing is really nothing new. You can't even believe that because you think we're all on the forefront of change in dentistry. But what you're going to find out here in a minute or two is there is nothing new. People were doing what we're doing now, but it just went away. And I'll explain a little bit about why. Uh, I'm I have a disclaimer here I like to put in here. I was trained as a traditional orthodontist, and believe me, I did what I was taught to do for about 4 or 5 years before I began to question things. My father taught me to be a skeptic about lots of things. He was an engineering professor at the University of Illinois. One of the biggest gifts he ever gave me was to be a skeptic. But it took me several years before I really started to believe my skepticism and think, is everything I learned really true? Is there evidence behind it? I don't have a slide in here with this, but there's a article from a guy who was a professor at the University of the Pacific several years ago. It said approximately 8% of what we do in dentistry is evidence-based. Now, if you look at people's websites throughout the United States, people will say, "Oh, we have an evidence-based practice." I look at those websites and I just kind of laugh. So what you're going to learn is not really my ideas. It's just what I've learned from listening to the patients, and that's over the years being skeptical and basically questioning everything. Believe me, I don't have all the answers either. But let's get right down to it. Let's look at somebody, and we've all seen patients like this. And what does this mean to most dentists? In Southern California, where I practiced for 26 and a half years, that meant somewhere around $70,000 to 100,000 maybe for a full mouth restoration. To a cardiologist, they don't even look at the teeth. This means nothing. But in reality, bruxism is 6 times more common in patients who have sleep apnea. And that's what we're going to be talking about, all kinds of sleep-related issues. And sleep apnea, by the way, is really a terminal diagnosis. It's long before you get sleep apnea, you've got real problems. So it's not just whether someone has or doesn't have sleep apnea. So this is a gentleman that owns those teeth, and that's his face. And you say, would you look at him and say, oh my gosh, he's got a real problem? Well, if you take a sleep study and look at it critically, this is what the sleep study says: 454 abnormal respiratory events. And he had an AHI of 72. For those of you who know sleep, that's ridiculously horrible. He desaturated to 70% and spent 52% of the night at oxygen saturations less than 90%. You do not have to be a sleep physician to know that if you have a report like that, it's probably not a good idea to buy green bananas because you may not get to eat them. This is a very unhealthy person, and this guy will not live a normal life. And yet, what do we do as dentists? Most of us don't recognize that there's an underlying sleep problem here, and it's a serious one for this person. Now, I happen to be a runner. I went out for an hour run just a little while ago. I have some crazy thing about having to run even when it's cold like that. And I'm a big fan of looking at who the people are who win the Boston Marathon. I've run it 11 times. And I say, we are the gatekeeper of the airway. And here's a guy crossing this, and he's got a monstrously beautiful broad arch, as is the world record holder for that. He was the world record holder. Here's the guy winning the Boston Marathon. Both of these people have incredibly broad arches that we don't see in our population. That's because we're too civilized, and we eat what we eat. And these people who win these marathons are actually healthier because their jaws are forward and they have huge arches like this. And I happen to believe with that, the airway improves. So I told you we're not really doing anything new. If you go back to the early 1900s, and my grandmother and grandfather were born in 1900, and they grew up on a farm and had horses and stuff, and I know what they went through. But in reality, things were really pretty advanced in orthodontics. If you look at this, 1912 talked about treating before the age of 6, before the first permanent teeth come in. I'll just think about that. Eliminating mouth breathing. Here's another slide that uses the word healthy. Treat the patient, and all the teeth would come in, treat them in the primary dentition, and they would be a healthy person. The word healthy does not appear in the orthodontic literature very often at all, unfortunately. I like this one because I'm talking about beginning the treatments as young as age 3, but things got away and they weren't doing it anymore. In 1909, someone is even talking about brain development is retarded. Can you believe that? Talking about that in a dental journal about brain development being retarded. I love this from a public health magazine, a book from New York City in the early 1900s. Many of us, all of us have been to birthday parties, and you take a present. If you go to an adenoid party, you go there, you don't have to take a present, but you leave without your adenoids. And that's not a joke. This is a real thing. It happened a lot in the early 1900s, even the late 1800s. I know that for sure. I've read about it. And even way back in the 1860s, Dickens talked about mouth breathers not only having they're backward and they're delinquent, But more than that, and this is a big deal, there are a lot of criminality. People who have really long faces that are far back, they're not attractive and they don't get on the right side of society. And then bad things happen. So here's another one out of 1922 I like. Remove the causes of mouth breathing. But let's bring it up to 1930. And this is from Dental Cosmos. Realize this is a dental journal. The child should be asked to run with his mouth closed a short distance daily, causing a forced rapid breathing through the nose. The distance should be gradually increased until the child can breathe as freely through the nose as is necessary. 15 years ago, I heard Patrick McCune speak, and I'd run 19 marathons by that time, and I ran with my mouth open. I trained myself to run with my lips together. It didn't take very long. And here I am at the Boston Marathon in the 2023, the most recent time I've run it. And I did this as a publicity stunt. You can see that slide. I have my mouth taped. I don't need the tape there. I run with my lips together, and I do very well in my age group. uh, and I ran 26 miles with my mouth taped. Here you see the Wimbledon star, the woman who won it here in the middle. She trains with her lips taped. And here's another person in France who ran with his mouth taped. Someone that Patrick McCune knows. Now we all know that dentists are crazy people, do weird things. And here you have Frank Seaman. I've never met him, but he's from Colorado Springs, and he's really a nutcase. He runs up Pikes Peak with his mouth taped. He's older than I am. I'd like to meet him someday. He'd make me look sane. How about a sprinter for the United States running with her lips together? And look at the other two people there on that upper right with their mouths hanging wide open and looking. She's ahead of them, running very calmly but very fast. Now, these guys, if you've ever been to the hills in New Zealand, they're running on the hills in New Zealand. They're rugby players. And I want these guys on my side. But look what they're doing, training to be nasal breathers. And a soccer player from Norway, same thing. And you say, well, why isn't everybody doing this? What happened? Why aren't we talking about this right now? Well, lots of things happen. We won't get into it. But this is a gentleman who is very well known in orthodontics, and he is largely responsible for lots of extraction of teeth and treating in the permanent dentition. I don't have time to go into the history of the profession. Just know that that happened. And by the time I came along as a kid, I wore braces in 1958 as a kid. I had teeth taken out, and unfortunately, then I reversed that later on. But by then, people were only treating in the permanent dentition. John Remmers is a Harvard-trained physician, sleep physician. He passed away a few years ago, but one of the most notable, very well known, and a lot of patents on CPAP machine stuff. He made this statement: the sleep apnea would not exist if our jaws were forward. That's the most important word you're going to hear tonight, I think. Forward like our ancestors. You say, well, why do they fall back anyway? Well, let's explore that. Here we have Weston Price, who was a well-known dentist back in the 30s and 40s, who literally toured the world and went to very remote places. And he valleys in Switzerland, islands here, there. He toured the world and went to primitive places, but he found that within one generation, with the adoption of a Western diet, including refined flour, sugar, and milk, that faces would change. Tooth decay happened when it didn't before, and the faces changed in one generation. In my orthodontic training, I was taught that genetically, the facial determination was more genetic. There's literally no evidence to support that today. I can't go into all the details, but believe me, I confirm that's the case. But there's really nothing new. Going back to even the 1860s, George Catlin was a well-known painter and artist, uh, and photographer, who toured the world, toured the West, lived amongst the Native Americans, and wrote this book. He talked about how hanging your mouth open would make your face go fall back, and how the Native Americans were healthier than the Caucasians that he grew up with in Philadelphia. It's a very compelling book for 13 bucks. Get it on Amazon and you'll enjoy it. It's very comical, actually. Don't get it if you're easily offended, because they'll say things like calls about the Native Americans, he calls them savages. He's not politically correct. But the message is there. Now, let's get a PhD who teaches anthropology at Harvard University, Daniel Lieberman, puts it in really easy to understand words here. We're not exercising the facial muscles the way we used to. We're eating food that we don't even need teeth for. Go look at the yogurt that the kids have today. They suck it out of a little tube. Most kids don't even need the teeth to eat what they have today. And that's what's has caused our faces to fall back. Look here at a young guy going from age 8 to 16, and then that interim, you'll see a black line. That's known as the Bolton norm, which is we consider it an ideal. And it's superimposed in the forehead and the bridge of the nose. And what you're going to see happen on many of these pictures, this boy's lips are apart in many of them. And his mother did not listen and did not do any myofunctional therapy. So his face continued to fall back from that norm. When you see him at almost age 17, you see his jaws are back, an inch and a half. And that is, he doesn't look any different than most other kids his age that are that age. Most of our kids look like that today. And they have airways that look like this. Now, if you know David Hatcher, he's the oral maxillofacial radiologist. He's written articles that an airway that's this small is almost certain to have sleep apnea. And this boy has sleep apnea, diagnosed at age 15 or 16. You say, well, that's fine. He can wear a CPAP machine. And then you get this study out of one of the most respected medical journals there ever was, the New England Journal of Medicine, out of the University of Flinders, reported almost 10 years ago that continuous positive airway pressure, the sleep apnea machine that everyone has, does not reduce the chance of strokes and heart attacks, the two most important things that people worry about with sleep apnea. You're going to feel better in the morning, but that doesn't mean you're going to live longer. They need to know this, but they don't. So the only way to really fix that is for him to have double jaw surgery to bring his jaws forward, and yet he's got perfectly straight teeth. Let's look a little more at some of the medical aspects here that are in the literature regarding what happens here. Bring it up to date more. To here you have Leela Cavendish Gozal and David Gozal. He was past president of the American Thoracic Society and one of the best known names of all of sleep. And here's an article talking about brain tissue. One of my big heroes, Ron Harper from UCLA, a neurobiologist, the structural damage accompanied by impaired neural functional responses to blood pressure and ventilatory challenges in essential regulatory areas. This is some big words to say this isn't good for our kids. And here he is again. You can see motor coordination is at risk. And you can see long-term risk for hypertension. These are not good things. Back to David Gozal, again, another in the refereed literature of 2017, making decision, emotions, speech, perception, decision making, and self control. This is all incredibly important stuff for our kids' health, and yet we're ignoring it. So, my question to you is how much brain damage are you willing to accept for your children? I think we obviously know nobody wants any brain damage, but that's what's happening. And if you're not screening for this, it's happening. There's a big segment of the population that has this problem. There I am in my sandbox in 1948 in Champaign, Illinois. My mouth is open by 2 or 3 millimeters there. And my pillow was wet every morning of my life until 15 years ago when I met Patrick McCune, and I've been taping my mouth every night, eliminating my colds. But that cute little kid with the wavy hair there, you know what? He's got a long face now. That would be me. And I don't like the long face, but that's how I got it. So here we take a mouth breather. Look at her lips. They're apart almost 20 millimeters, really, 15, 20 millimeters. And she's not that healthy. They live in Seattle, and I was practicing in Los Angeles. And the dad had four bicuspids taken out and has serious sleep apnea and serious health problems. So he's highly motivated to send his daughter, fly her down to Los Angeles to see me, for me to do something that no one else was going to do. Now, what we're going to do is move her face forward. And there's a little thing here saying this is not this SOC means standard of care. What I'm going to do here is not the standard of care, but you're going to look at it and say, why couldn't I have that for my kid? We do the unthinkable. Orthodontists are taught if you move teeth forward, you'll push them off the bone support. I've been doing it for more than 40 years. I've done it in my own mouth, and I've done it in my wife's mouth. I've done it for many more people. But you see, we create an overjet. She had a class one occlusion. We create an overjet purposely. Now we bring her lower jaw forward with a certain kind of appliance. It's not easy to wear, but she learns to keep her lips together, and she now has no overjet. Her lower jaw is forward. She's now, her mother reports, she's 2 grades ahead in her schoolwork, which is pretty nice. You want your kid to be a good student. You can see coming from the left to the right, she's really close to that Bolton norm, and very few kids are even close to that. That is considered an ideal. And when you see that superimposed on a face, anyone who has that kind of face near that norm, your eye will immediately tell you that person is attractive. Male or female, they have a balanced face. And with that, this is what goes along with it. On the left, you see this is what this girl looked like prior to treatment, and her minimal cross section of her airway was pitiful. That's like a drinking straw or even a cocktail straw. On the right, you see it's massively improved to 186.1 millimeters squared minimal cross section. That's a massive change. You can see the improved profile with the upper lip moving forward and the lower jaw moving forward. This is what you want for your kids. And this family was willing to fly down from Seattle to Los Angeles for me to do this for their daughter. So that's the little cute little girl there, but there she is in her mid-teenage years, and they're a very well-off family, and she competes all over the United States in equestrian events. Again, this is not the standard of care, and it's not being taught in any orthodontic program. I teach it in my Echo mentorship. It's not quick and simple and easy for anybody, but it works when the patient makes it work. Look at what happens from this boy on the left, where the Bolton norm is relative to his face, and there it is on the right. We had to wait to treat him in the mixed dentition and see how far back his face fell in those 5 years. He didn't get his upper front teeth in until he was almost 11. What we would love to do is to treat him long before his face melts back like that. It'd be lovely to treat him in the primary dentition. Makes sense, wouldn't you think? Here, common sense. Why wouldn't we treat earlier? Well, this is a Journal of Clinical Orthodontics uh, uh, review from last November. They do a survey of people, and orthodontists, the main minimum age to start any kind of treatment was 7.4 years, and it ranged from 3 years to 9 years with a single outlier at the lower end. I actually was polled for this, and I am the single outlier. If I hadn't been there, that average would be even higher. I treat and want to treat at age 3. I want the treatment done prior to the eruption of the first permanent tooth. I can make a very strong case for that. We shouldn't be straightening teeth in adolescence. There are ways to change things so that that doesn't have to happen. Nobody better to have that happen than a woman like this woman who had 4 teeth taken out. You see her on the left. She had headaches and sleep apnea, and we reopened her extraction spaces for her, got rid of her headaches, her sleep apnea, and she loves me because of that. She also lives near San Diego, approximately 4 hours with traffic from where I live north of Los Angeles, 3 to 4 hours on the 405 freeway, which if you live in Southern California, you know that's no fun. But she's the mother of these next 2 kids, and she would do anything driving past hundreds of orthodontists for this treatment. Now you look at this girl's smile and her deep bite. Those tip back upper incisors are literally trapping her lower jaw from developing forward. And her upper front teeth are 13 millimeters too far down and back. Left alone, this girl will have TMJ problems almost certainly, and her lower face will fall back. And by the time she's in her 30s or 40s, I would have, even if she's not overweight, I bet she has sleep apnea. So you see, she's not even back that far from the Bolton norm. But think about it. Is that an attractive smile with gummy smile like that? The upper teeth are down so far. They're 13 millimeters too far down and back. So we do some crazy stuff and we move them up and out. Look at the overjet I created. And I've got braces on the lower teeth. And you say, oh my gosh, you're straightening her teeth. Those are teeth that are going to fall out. Dr. Hang, you're ripping these people off. You're putting braces on baby teeth. You're a charlatan. Well, here she is with no more gummy smile. And if I were to treat her again, I treated her years ago, I would expand her arches more. I learned along the way. I've done many things. I don't know what happened, but we just lost that. Oh, there we go. Sorry. Uh, and so here you see her smile goes from a gummy smile to a nice smile. And you see her face has improved dramatically. This is her sister, and her mother has already witnessed that she's stopped breathing, apneic episodes. And you already know what happens with that. One night of reduced oxygen saturation with these apneic episodes, and she will be having brain damage. That's not a joke. There's plenty more books out there to read about that. The literature's there. And her maxillary anteriors are already down 12 millimeters, and her face is worse off than her sister. So we do the unthinkable. We blow her front teeth forward and create a huge overjet. Then we bring the lower jaw forward, and here she is about a year later, and you can't see the overjet's been reduced completely, but no teeth in there yet. But her face has come forward dramatically. So the next case is going to come from Chicago, referred to me by Steve Sheldon, who was head of Lurie Children's Hospital Pediatric Clinic and one of the best known names in all of sleep. He's now retired. But he sent this little boy to see me from Chicago to Los Angeles many times. The little boy has Pierre Robin sequence, and everyone who's into orthodontics will know that the lower face does not want to grow forward in that case. He has sleep apnea diagnosed and failure to thrive. Failure to thrive really means he's not growing normally. And for those of you who are into sleep, you know that if he's not getting into good REM sleep, that he's not getting human growth hormone. So, hello, of course he has failure to thrive. We make no promises, but we develop the face. We expand laterally, but more importantly, we move the upper anterior teeth forward and then move the lower jaw forward. This is critical. And in cross section, you see the basically the drinking straw airway there goes into almost a garden hose kind of an airway on the right hand side. And there's Steve with his book, and this then gets published in Steve's book. Right there, those same x-rays are there, and it shows that the sleep apnea is gone. Whatever. Okay, sorry. So I followed up on this kid. They left Chicago and they live in Colorado several years ago. It was actually 5 years ago now. I checked in with the mom. I don't know what's going on here, but this is what she said. Can't thank me enough for what we did for him. So there are the pictures of him, and he's apparently a nice, aggressive tennis player. So he'd be in college now. But basically, had we not done this, think about it, he might have a lot of brain damage, would not be doing well. So people say, well, there's no evidence to support what you're doing. There's no evidence in the literature. All that does is prove that they don't know what they're talking about because there is evidence here. I don't know what's going on. Pardon?
Yeah, I don't know why it's just like blacking out every.
Somebody's playing a computer. That's what's going on. I don't know what's going on here. I'm very sorry.
Why don't you stop share and start sharing again?
Okay.
Thanks, Debbie. Hi.
Hi.
We're always glad you're here. Always
Oh,
giving
no,
help. But yeah, let's
that's not
reshare and see
computer.
if that picks back up.
It's not up, Deb.
Okay, so go back to your computer and catch it.
I have to.
Go to here
Yeah.
and go to your keynotes again. Sorry, everybody.
It's okay. It happens.
Okay, we're back to that same slide. Now, if I can get this off.
Hit share, and I think you're.
Technology is always great when we know how to use it, right? When it's
Great when it works.
That's right.
Well, and we're in a hotel in Chicago and a lot of things.
it may be that I was on my computer and I'm not going to touch my computer now. Yeah.
Please don't.
There you go. Good deal.
Okay. Okay. What this is now, from this literature, we did a study of consecutively treated cases that I use with this technique. And you see right here, X-ray on the left of a class 2 patient who was scheduled to have 4 teeth taken out and wear a headgear to move her upper teeth back and correct her class 2, the standard of care in the orthodontic profession. They came to me, and what did we do? We moved her upper jaw forward 8 to 10 millimeters. Every class 2 has a recessed maxilla. Every class 2 has a recessed maxilla. So we move both jaws forward, and you can see the improvement in the airway here. I saw this X-ray in the year 2000, and that's when my life changed, and I realized what a big deal this was all about. It's crazy. And in our study, we found a 31% improvement using this technique in our sample of patients at the dorsum of the palate, 23% at the angle of the mandible, and 9% here. This is monumental. And I've shared this with ENT specialists, sleep doctors, and Steve Sheldon himself said this is the most important thing that's ever happened in the history of my being in a sleep practice. This is monumental. It's in the refereed literature where someone says there's no evidence to support orthotropics. Excuse me, that only means they haven't read the literature. So in an ideal world, all of this would be completed just as it was being done 100 years ago. And we teach this in our mentorship. So lateral expansion is what's being recommended by everybody, that and giving out preformed appliances. And we'll talk about that. I understand there's a question about that. But let's look. Here's lateral expansion, and we have a massively expanded primary dentition. This is huge. No kid ends up with this. No kid is born like this in Western society. This is very effective with his appliance, but it does nothing to grow the face forward, unfortunately. And he has sleep apnea at age 6. Here's a gentleman who's in his mid-teens, and he's worn a Alpha appliance, and he's got a maxilla that's wider than probably anybody on this call. Anybody on this call. And look at his face. He snores and likely has an issue, and that's his airway. I can tell you, I would put big money on him having sleep apnea later on. Here's someone diagnosed by a camp counselor with sleep apnea. You say, well, why didn't the pediatrician diagnose the sleep apnea? If a camp counselor can do it, a pediatrician ought to be able to. And that's a pretty good question, isn't it? So it's too late for us to do our orthotropic thing to develop the face forward. So all we can do is what others are doing, or some of them aren't even doing this, expand the upper and lower arches. So we do that, and this is his airway before, and this is a good airway to have brain damage with. And I think this boy has brain damage. The lights are not home, the lights are not on, and there's nobody home. He's not okay. I treated him. They drove 2 or 3 hours to our office, but I didn't change that. I think he has brain damage. You can see what we did. We expanded, and you think, oh my gosh, look at that lower expansion screw. And you say, well, there's no midline suture there. And I say, yep, you learned your anatomy just the way I did. And I would learn that I was going to push the teeth off the bone support if I did this, but I know it doesn't happen that way. I have a son who in next month will turn 50, and he was one of the guinea pigs that I expanded both arches with. And you know what? It's nice. He still has his teeth. So this is what happened when we expand this kid. He gets improved, but that's not a good airway on the right. He still has apnea. So we advance his teeth, which of course orthodontists have been taught never to push the teeth forward because they're going to push them off the bone support. But we do that, and you can see that we haven't pushed them off the bone support. The gingival tissue is perfectly normal. And his mom says he doesn't have any apneic episodes. But does she really know? And the answer is no. He gets a sleep test done and he has apnea. So you look at him and you say, look at that boy. He doesn't look like any different than an awful lot of kids today. And the only way out of this for him is a very aggressive surgery to advance both jaws. So remember John Remmers, he said this, OSA would not exist if both jaws were placed properly forward in the face. And none other than Christian Guilleminault, the father of sleep apnea treatment, and he has over 400 articles in the refereed literature, says this: it may not happen. Retrognathia and anterior growth rotation pattern may not respond. And I've been saying this for years. You cannot expand your way out of an anterior posterior problem. Said that at an AACP meeting in Salt Lake City this summer. Will make 9 years. I'm saying it forever. So now this next patient, think about what you're going to do for this next patient. Look at that little boy growing up in the Philippines with his mouth open 20 to 25 millimeters. That is a horrible situation. Would you call 911 now? You should. You should be treating him. He's no better by his teenage years, and then he goes and gets orthodontics done and has 2 teeth taken out. So he has no overjet. And this is what he looks like when he comes into our office. He has no chin because the extraction and retraction of those upper teeth has caused his lower jaw not to grow forward at all. That plus his chronic mouth breathing. So when I walk into the room, I understand my wife has taken the health history, and he is on blood pressure meds, and I took his blood pressure, and that's what it was. I looked him square in the eye, and I'm not joking. I said, look, this is a serious problem. His cardiologist never asked if if he snored, and didn't suggest a sleep study. I looked him square in the eye. I said, you need to do a sleep study. If you don't do it, you're going to die. And I was literally I said it that way. He got the message. 2 days later, he had a sleep study done, and he desaturated to 65%. Now, what happened the sleep clinic, when he got to 65%? They woke him up, sent him home. Do you think maybe it had something to do with the fact that he's highly likely to have a heart attack or stroke when he desaturates like that? That's not healthy. So this is an emergency case because this is a very, very, very unhealthy man. So look at him forward like this with surgery, double jaw surgery. And his airway went from the left, which is honestly, that airway on the left is bigger than many of you on this call right now. And it's massive on the right-hand side. So much so that his blood pressure dropped within days after the surgery. He emailed me from St. Louis where the surgery was done. That was a dramatic drop in his blood pressure, and it has stayed down ever since. So his mother wanted to meet me, but I already was in the process of leaving Los Angeles. But she wrote me this text message when she was going to come to Los Angeles. She wanted to thank me for saving Bobby's life. And here's Bobby at the Golden Gate Bridge in San Francisco, and I got this email from him. I thank my lucky stars for having met you. You changed my life, and for that I'm forever grateful. There's nothing special about me. I just am persistent about this, and I'm trying to spread the word. This could be you, having recognized the problem and treated this man to save his life. He is a poster child for extraction, retraction, regret syndrome, which is a problem that my wife and I have recognized. In 1989, I began reopening extraction spaces for a woman, and I'll show you to you in a moment. But it took me years to realize that there is such a thing as extraction, retraction, regret syndrome. It is a very real syndrome. And ERRS is an acronym we came up with because it means mistake. It is very real, and it's not funny, and it is preventable because retraction is preventable. Here's another person. She has a class 1 occlusion. You say, well, what's wrong with that? That's perfectly normal. Really? Is having blood pressure 179 over 21 when you're on meds, on blood pressure meds, and the cardiologist never asks if you snore or suggests a sleep study done? Is that normal? She has a sleep study done, and she has an AHI of 57, which for a woman is astronomically high, and she desaturated to 84%. That's another patient who might not want to be buying green bananas. So she has double jaw surgery, and her blood pressure goes from there. Her surgery's done in 08, and within just a few days, 4 days, her blood pressure starts to drop. And in another couple of months, it's down to a relatively normal level. And you look at her airway. Now, if I were to treat her again today, there are things I might do which would make that airway even bigger and better. But she's a whole lot healthier with that blood pressure, or excuse me, not having to be on meds anymore. So that's what I say. This really is about health, isn't it? And that's why we in dentistry have this. We've been handed this. The ADA told us in September 2017 that we should all be screening for sleep apnea. So let's get back to where did it all start? Started in 1989 in Rutland, Vermont, when I was practicing there. Actually started in 1985 when this woman came in to see me, but I sent her away. These were her teeth. She'd had upper lateral incisor teeth extracted, and the cuspids were brought into the lateral positions. She was retracted like crazy. In 1985, I didn't know what to do. I sent her away. 1989, she came back. She was desperate. She said, "You have to do something." And I told her everything in the world that might happen, like you'll produce an open bite, might push your teeth off the bone support, might lose your teeth, have to see a periodontist. I can't promise anything. Frozen open bites can only be corrected by surgery. I can't promise a thing. She says, I don't care. So she was a guinea pig for me, changed her life and changed mine. I pushed these upper front teeth and the lower front teeth forward like crazy. You can see where she has a crown on the lower and a bridge on the lower right. We advanced upper and lower anterior teeth 4 to 5 millimeters, which if you were to have an orthodontist in an academic situation tell you that you're going to do that, they'll tell you you're going to cause tooth loss. Do they have any evidence to support that? Not really. Long before implants were around, she got a bridge to replace the missing laterals. She regrets that now, and I can tell you that because I now have reason to know that. That's what she looked like with her lips, pencil thin lips. And she went to Florida there on the right. She came back from Florida with a tan like that. And her mother in Florida said, "You have lips." That's what changed when we pushed her teeth back forward. And her profile went from being caved in like that to a nice profile. That's her after the treatment. I saw her in Bed Bath and Beyond in Rutland, Vermont several years ago, and she went to see the orthodontist who bought my practice there, and he's treating her daughter. And this is her teeth 23 years after the treatment. No more recession than anyone else her age. But the reason I'm showing this to you now is that on New Year's Eve of this year, I was in a shoe repair shop in Rutland, Vermont, and she walked in. She lit up her face, came over and gave me a big hug, and I smiled at her. She changed my life. I have people from every continent except Antarctica contacting me, and I had people from more than 30 states that I was doing this kind of thing for, and several foreign countries, all because this woman was persistent. Now look at her. 36 years later, the constant headache which she had is completely gone, as in gone, gone, gone. And trust me, her teeth are tight. They're not going to fall out. She's now 63 years of age. We took a cone beam X-ray. What would we find? I don't know, but I don't care. But she's not going to lose her teeth. If you want to die with the same, like have the amount of bone that you have when you're 18, the best thing you can do is die when you're 18. Most people don't want to do that. So I say, wouldn't it be nice if people actually in our profession read the refereed literature and believed it? And if you don't believe it, here are 7 articles from the refereed literature, and all of them confirm that you can advance front teeth like crazy and not cause recession and or tooth loss. These 7 articles are routinely ignored. Which brings me to the point where this is one of the problems that people are saying, well, you got to do surgically facilitated orthodontics and you got to pack bone in here and all this other stuff to avoid the problem. From my perspective, it's a problem that doesn't exist. People have been asking all along now, what's the problem with sleep apnea? What's the problem with retractive orthodontics? Can it cause sleep apnea? Well, here's a woman. I reopened her extraction spaces for her like this, and I'll tell the short version of this story. And she went and had a sleep study done and said this. Despite the fact that she gained 10 pounds, which would make it worse, probably, or she would have a much more likely chance of sleep apnea. She has no sleep apnea. By opening those spaces alone, she got rid of her sleep apnea. So people say, you don't have any evidence? Well, here it is. Someone will say, well, it's a sample of one. Well, I admit that. Absolutely, it's a sample of one. If it's you and you get rid of your sleep apnea and you live longer because of it, would you like that? We need to do studies about this kind of thing. So I say to you, I've been using this slide for a long time. Do you think that the retraction, could you retract enough to cause sleep apnea? And when I show this slide, there's never been one person who said that it could not be done. Never one. I've asked people to raise their hands and stand up in a meeting if they thought you couldn't do it. The next question is pretty easy, is say, well, if you don't, how far can it be? How can you retract before it becomes unsafe? And nobody knows. And I don't either. So question is, if you don't know where safe becomes unsafe, to me, the obvious question here is, how could you ethically and morally retract at all? And that's my whole point. For those of you who need a good graphic here, that's my foot. And yes, I painted my toenails red. I don't normally do that. And that's my wife's high-heeled shoe. I have a size 14 foot and she doesn't. But I put it here to help you understand God gives us a size 32 jaws, 16 upper teeth and 16 lower teeth. The trouble is our faces fall far back like crazy and we have wisdom teeth taken out. Then you take four bicuspids out and that's 8 teeth gone. You're dealing with a size 32 tongue and a size 24 space. It doesn't fit so well. So what about, is the airway the only thing related to extraction and traction? Here's a young kid treated in my town, but not by me. Cute little boy, look at his smile, deep bite. What would have happened for him if we'd developed his upper teeth forward when he was in the mixed dentition and his mandible forward? And he didn't have teeth taken out like this, made him look like that after his treatment. And 8 years later, when he's working at a transmission shop, all of his buddies who work there call him old man. He's in his early 20s. That's what happened to his face. And trust me, I don't believe anyone here would believe that that would have happened had not he had this treatment done. From the front, look at it. It's pencil thin lips that hardly exist. And this is his smile on the right-hand side. Look at the smile on the left. We could have made that even better by advancing his teeth and getting his whole lower face to come forward. Now you say to yourself, what if this was your child? Wow. So let's explore what's the official position of the profession on the relationship between orthodontics, retraction, and airway issues. And there I am in Marco Island, Florida, 7 years ago, just a couple weeks ago. And here's one of the speakers, one of many, but it's all the rest of them are saying the same thing. And he says bicuspid extraction is not related to sleep apnea. And this is his article, which is out of the refereed literature. And it says there, dental extractions in conjunction with orthodontic treatment have a negligible effect on the upper airway in adults. Okay, if you believe that, that's what almost all of the speakers would say that, except for one. You're going to see him in a moment. But if you're a 10-year-old boy with a mobile device, probably a lot smarter with the internet than I am, and better with a mobile device, you could probably find these articles yourself. Here's one. The pharyngeal airway size became narrower after the treatment. This is out of 2012. Another one here. Again, the airway narrows. This is from China. Here's another one. This is from Turkey, reducing effect on the middle and inferior airway dimensions. And here's Christian Guilleminault from Stanford talking about tooth loss and dental agenesis. And he gets around to the fact that permanent teeth extraction presented with sleep apnea recognized at a later age. And there's another one, number 5, premolar extraction and incisor retraction further reduces the airway, as does headgear and is contraindicated. Number 6, this is another one talking about, this is about, again, treating in bimaxillary protrusion. And this is a meta-analysis. Again, significant correlation of bicuspid extraction orthodontics and pharyngeal airway dimension reduction. So here's Christian Guilleminault, who was the main speaker there and the best known name in all of sleep. He died 6 months later. But this is what he said, and another speaker who was an orthodontist made fun of him 2 days later. And this is what Guilleminault says: you can't be a mouth breather. The end result of all sleep apnea treatment is everyone must become a nasal breather. He also said this in his French accent: you must stop pulling teeth. And more than that, he says you got to treat very early, as soon as the problem is recognized. And the AAO has had a brochure for years: the age 2, see the dentist, and age 7, see the orthodontist. We have to treat earlier and make the case for treating in the primary dentition. The interesting thing is, in the white paper, which was published after this, there were 14 people who signed it, realize that sleep apnea is a medical condition that cannot be diagnosed by a dentist. And yet 9 of the authors, signers on that were orthodontists. 5 of them, I believe, were in academia and 4 were in private practice. There was 1 lawyer who signed it, 1 academic, one staff liaison, and 1 sleep physician. Would it not make sense to you that Christian Guilleminault he spoke at that meeting, that he would have been a signer? Someone would have asked him his ideas. Just think about it. Food for thought. So I'm going to share this with you just to let you know the kind of stuff that I get off the internet. And this is from a woman who's 53 years of age. And I'm just showing you some quotes from her very lengthy email to me. She grew up in India, and she lives in Dubai. And you can read this as well as I. And here this gets really emotional. She went to dental school, and by the time she did that, I began to hate myself and could not bear to look at myself in the mirror. By then, I was studying dentistry and could figure out that I had ruined my face. These are really strong words, aren't they? Just look at those things, quotes in green. I felt that my tongue was in a very tight space. My mouth had become really small and constricted. And I suffered from extreme anhedonia. I didn't know what that word meant. I looked it up. It means she never experiences joy. This is kind of compelling. Here she is. I lived only the first 16 years of my life. After that, everything spiraled and I've just existed. I get stuff like this and have for many years because I have a lot of stuff on the internet about extraction, retraction, regret syndrome. I feel like an absolute freak, to be honest. I hope this drives it home to you just to know how important this is to people. And there are many of them that are suicidal. And I know of people who have committed suicide. Fortunately, I've kept some from committing suicide, and I have their cases to show. I can show them. So please don't think that everyone who's had teeth taken out is going to end up like this. But the fact is, how do you know which ones are and which ones are not going to? So I just thought I'd put a couple teasers out here. If you want, I've got lots of stuff. I got nothing better to do in my retirement, but together new lectures. And here's one that I just put together recently. Yeah, talk about MARPI and SFOT, which are very popular now. I have some interesting thoughts about those. How about this? Non-retractive airway-friendly treatment for adolescents and adults, basically, which is the diametric opposite of traditional orthodontics. Or this: everyone knows that tongue thrusting causes open bites. It makes it so that the upper teeth don't come down enough. But the fact is, I have a lecture that will make you, I think, decide that this is one of those old wives' tales or that is not real. So I'm going to finish here by showing you this slide, and I'm going to challenge you to say, what would you do? This is a little baby in the mother's arms right there, and it may look cute and innocent, but we're going to show a little video. This takes 12 minutes, and we're going to show what happens when either you don't do something or you do the wrong thing. So just watch this. This is a Facebook post from a friend of mine back in California. She thought it was really cool. The circle of life is so beautiful, but the fact is, it's not okay, and we must change this perception. That's what it's all about. Uh, I'll leave this slide here. This is a advertisement for our early childhood health centered orthodontics mentorship program, which starts actually in April of this year. I know there was one question that Whit said in advance, do I use preformed appliances? And the answer is no. Uh, I know they're very popular. I have actually have a segment, a lecture segment on that about why I do not. And I feel very strongly about that. I know there are other people that are recommending them all the time. I happen to believe there are quite a number of negatives about them, not the least of which is a headgear effect, which many claim there isn't, but I believe there is. Uh, so other questions I'm happy to answer here.
Let's see here, Bill. There's one from Dr. Wells that says, is it the way you're moving those teeth forward that bone loss and recession isn't an issue? Because I've had recession when moving lower anteriors forward too much on one or two occasions.
And that may happen for a little bit of recession sometimes. I mean, I've been moving teeth forward for 40 years. I got to the point in the early 1980s, I said, I can't take out teeth anymore. And I stopped doing it completely in the early 80s, more than 40 years ago. And believe me, I was scared to death that I would be causing problems, and I was very cautious about it. But after doing it for 40 years and taking long-term records, it is not tend to be a big issue. A tiny bit of recession here and there. I mean, I've got some recession on my teeth, but you know what? I'm 79 years of age and I've had recession since my 40s. My dad died at 95 and he had most all of his teeth really. Uh, and I don't know how long I'm going to live, but I'm pretty confident I'm going to die with my teeth. And again, as I said, if you want to have all the bone you had when you at age 18 when you die, then you better die at age 18. You may lose a little bone along the way, but the goal is to keep your teeth for a lifetime. And I do not think you're jeopardizing them when you're advancing them. That I want to caution you, however, if there are any significant periodontal issues out there, then don't be silly and do that. Now, there was a expose on this 3 years ago. Actually, it's going to be 3 years in February about this, and there was lawsuits about a certain appliance out there. And I know the situation, and I know that those patients should never have had the treatment.
Okay. Brenda has a question, and that has to do with Invisalign. And said, could you please talk about using Invisalign for expanding arches, which of course is common practice?
I don't actually use Invisalign, and there's a reason. I'll explain to why. I'm not a big fan of interposing plastic between the occlusal surfaces of the teeth. You have a millimeter of plastic on an Invisalign tray. You put 2 millimeters in the second molar region. You prop the patient open, and what do? You make it more likely that they're going to be a mouth breather. How do I know this happens? Because I did it for my own son way back when, that son who's going to be 50, and I had his teeth perfect. I straightened them, they were perfect. And I put invisible retainers in, and within a short period of time, he developed an anterior open bite and was more of a mouth breather than he had been before. That's why I don't use Invisalign. Now, people don't care about that, but I do. I don't want open bites and I don't want faces to be made longer. I also, from my friends who do Invisalign, I understand that they're not a very effective way to do broadening. And I have a protocol that I teach where I can broaden the arches in adults just the way I can in kids without surgery, without temporary anchorage devices. And I have a protocol that you can get probably 8 or 10 millimeters in many patients, 4 or 5 in almost all. And we have our ERRS mentorship, we talk about that. But if you really, really, really want to get expansion, Invisalign would not be the way I'd want to do it. You have to go at it more aggressively than that.
Okay. Kristen was asking um, about hygienists getting involved in your program.
In probing.
In your program.
Oh, I no, I love it when hygienists. I'd love to have them come with the dentists who come in the program. The more team members you have, I encourage it completely because they're the ones who can take it back to the office. They're the ones who can recognize. We want you to recognize the problems. They're easy to recognize. We teach all of that. And more than that, hygienists can, if they want to, can become myofunctional therapists. And myofunctional therapists are they're more valuable than we dentists are, than we orthodontists. They're the ones who can get these kids, train them early to become nasal breathers. They're in the front line of the defense here in this
Mm,
airway paradigm. So
mm. Okay, that's great. Um, Todd,
our program is not for hygienists.
yeah,
Only we'd love to have them coming with the dentist. Yeah, sorry, my wife
yes,
reminded
I
me.
know, absolutely. Um, Todd mentioned that there evidently, I have not read it, was an article in JADA this last month that may say some things differently than what you're saying. Have you read that article yet?
Of course, I've read it. I've also added it to my lectures. Uh,
Okay. I
uh,
don't know what it said. Maybe you can fill us in.
well, maybe it has to do with TMJ issues. That was the one that I thought was, and that was out of the Ortho Journal actually. Sorry about that.
Right. Okay.
Uh, I read because there's something about the ortho about TMJ issues, and I have a great segment on that, which is
Okay.
very different. But maybe I'm not familiar with
Yeah.
art.
That's fine. We won't comment on it because you haven't had a chance to read it. Uh,
Please email it to me, and I'm happy to comment.
yeah, please,
Yeah,
Todd,
happy to do it. Please send it to
send
me.
that to Dr. Hang and he can respond to you.
Sure.
Yoko asks, how fast do you typically expand for adolescent and adult patients?
How fast
Yes.
you can you can when you're dealing with young kids, we like to do what we call semi-rapid expansion, which is about a, a 45-degree turn on a screw every day. In a matter of a week, you can have a millimeter of expansion. In reality, we tend to go slower than that, and I certainly go slower than that in an adult. That would never work with an adult. And you're taught that the midline suture calcifies and you can't expand the maxilla. But I have a whole lecture segment on expanding the adult maxilla.
Okay. Okay. Um, Here's a question. It says, as a general dentist who recognizes these issues, the problem is finding orthodontists with like-minded philosophy to refer to. Is there any kind of reference you can give us for finding orthodontists who understand these issues that you're presenting?
That question comes up all the time, and I've tried my best. And very few orthodontists are interested in this, and they've been taught everything that I was taught, and they really haven't asked the kind of questions they need to really start to question their own training. If they did, they'd be where I am, because I had to follow this. I was if I didn't change, I was going to have to get out of the orthodontic profession because I couldn't stand to do what I was doing. And that's how bad a deal it was for me. Uh, uh, most general dentists, the people that take my course are general dentists, and they've tried like crazy to speak with an orthodontist, and they just won't listen, and they'll badmouth everything relating to this. And I don't want to get into all the details, but I've heard this story so
Mhm.
many times. It's
Mhm.
very sad. If you have an orthodontist, I'm more than happy to do a Zoom call with them and
Mhm.
try to encourage them to take the course. I have had some orthodontists who've taken it, and they do okay, but they're the ones who should be doing this because they have all the technical skills to do it. It's a matter of the
Mhm.
diagnosis and doing things basically diametrically opposite of what they've been taught.
Mhm. Okay. Kristen Evans comments and says, please screen for low bone density before treatment, especially in high risk individuals.
When I exactly, and whenever I was having issues like this, if ever I had a thought at all of what I was doing, I had a very good periodontist that I work with all the time, who who I I would refer to. I didn't want that on my shoulders. If I had any issues at all, I wanted the periodontist to tell me it was either okay or not okay.
Mm. I won't name this person, but she says, I recognize this, but my doctor's not on board. What can I do? Maybe one thing you could do is have your doctor um, watch this study club meeting because we'll have this online. And so if you can get them to watch the presentation, I think that would be really helpful. Um, and
Great
so
idea.
something else. Yeah. Um, okay, I'm just reading through. How do we get our orthodontist to understand no extractions?
I have articles, and if you go to my website, I'm going to go one more forward here. This is my you can go to orthotohealth.com, and there's tons of stuff there you can have them read and look at. For those who are open-minded, they can read it. Most of them will look at it, and probably within a few minutes they'll click it down and say they don't want to see this, and then they'll call it gibberish. The fact is, they probably know deep inside that what they're doing is not so okay. There have been so many parents that tell them that, and they have to defend what they're doing. And you've got James Nestor's book out there, Breath, which came out 7 years ago as #6 on the New York Times bestseller list, published in 37 languages. Mothers today are very well informed, and the ones who've had teeth taken out are the best mothers. They will move mountains, and they will fly their children to somebody's office to have treatment done that's going to do the exact opposite of what was done for them. The point is, you if someone's really wanting to do this, the problem that they'll have is keeping up with the demand because the demand is there. People drove past hundreds of orthodontists to see me. And it's not because of my pretty face, it's because of what I was doing. And there's not a reason that any of you can't do the same thing. Just have to know what you're doing and do it in a very very measured fashion. And that's what our mentorship is all about. I get up in the morning and I'm on the internet every day responding to people's posts of their cases that they want to treat or have ongoing. This is a true mentorship where I hold your hand over the internet so that you're not going to make mistakes. I wish I'd had this for me to learn. I went through the wilderness and made all the mistakes in the world in the process.
Hmm. Okay. Well, and we are 100% behind you. And
Thank you, Whit.
you are our mentor. And so we are, one of the reasons we wanted to have you on tonight was so that people could be introduced to your work and your training and take advantage of that. Here's a question from Joanne. She said, how about night guards? Do they cause mouth breathing?
Uh, in a way, they can, and because they add vertical dimension, and that's a big issue. Uh, Mouth breathing is not good, and if you're going to use one and it causes someone to have mouth breathing, then why don't you get some tape? Get the paper tape, and you put one piece right across here, and uh, and you'll stop. It'll keep your lips together, and you'll be a nasal breather. I used to get 2 or 3 colds a year before I started taping my mouth, and I hardly ever get a cold now. My pillow would always be wet if I didn't tape, but it's Patrick McCune teaches it, and that might be a good thing.
Hmm. Yes. Um, I had a funny experience with Patrick McKeon. Actually, Bill, when he first came to the United States, he spoke at the American Academy for Oral Systemic Health about 2017, and I was responsible for introducing the speakers in one of the two room lecture halls that we had going. And he was the first speaker that morning. We didn't know each other, and he'd just written his book. So they said, "Tell him about his book." And I read the cover, and it was just about breathing. I thought this couldn't be anything valuable. So he spoke, and I actually slipped out, went into the next lecture hall, and listened to another subject. And a month later, somebody was talking with me, and they said, have you read this book? The Oxygen Advantage. It's revolutionary. Fortunately, I had purchased it, so I did read it. And since then, of course, Patrick's been a big hero of ours, but very
Yeah,
interesting how, when the student's ready. Um, Bill,
exactly.
thank you, thank you, thank you,
You
thank you.
bet.
Thank you for being out there on the front lines.
Thank you, Whit.
Taking
Happy
a
to.
lot of the shots for the people that from the people that aren't open-minded
Yeah.
and trying to understand what really is going on behind the scenes. And so you've opened our eyes tonight, and we're so grateful, as always, and we just appreciate you so much. And Debbie, and want
Thank
people to
you.
come learn from you, and so take that information and go get together with Bill. He's a super great mentor and just selfless and working day and night to make this a better world. He and I are getting older. We don't want to go out without these changes happening. Just, oh yeah, he's a guy with great ideas. What was his name? And so we've got to see this turn into a revolution soon, don't we, Bill? Um,
Exactly.
yeah. Um, One of the things that we're going to wrap it up here in just a minute, but Laura, I wanted to ask you because we just got back from a most exciting event. A few of you were there with us, but we just wanted to comment on momentum. And so, Laura, tell them about what we experienced at the Rocky Mountain Dental Congress just 2 weeks ago.
Yeah, it was a great event, but we did the three screens, one story, and that's really a big momentum that we want to bring to our community. And it has everything to do with what Dr. Hing is talking about. One of the screens is sleep. We need to screen for sleep because we know that this airway issue is such a big issue. And whether it's in our children or adults, the second screening, of course, I always say is saliva, my passion. And then the third screening is sugar. So we call it the three S's: sleep, saliva, and sugar. And during that, Dr. Wilkerson and I had the amazing ability with Dexcom. They came into our meeting and we got to place on over 350, I think it was close to 400 Stellos. I still have mine on. If nobody knows what that looks
I
like,
do too. Yeah.
I'm going to show mine.
Oh
There it is.
my.
You got to put those on. You get to follow your glucose. And what I find so amazing is just like what you're talking about, Dr. Hang, is this feedback, right? That people are able to have such healthier lives by a simple, well, it's not as simple, but a simple little solution that we can just start taking steps. But I love that because it's even like biohacking, like you're saying, some mouth tape, right? Getting us to breathe through the nose, just learning some of these fundamental principles. And to me, this is where that momentum is happening. Our community is learning that we can actually start screening for these things to take a different action.
Yeah.
So, Dr. Wilkerson, you got to be a part of it. We were a little nervous, Dr. Hang, I have to tell you, because having that many people to try to get coordinated to do one activity can be very, very difficult. But we had a huge response. People loved it, and we really want to bring that forward in our mission.
Yeah, that's something we're real excited about. It's just implementation. That's what we've really needed to focus on. And I guess as we wrap it up, we want to also let you know we'd like to have sort of an alumni meeting together from this study club in June. And Bill and Deb, we'd love to have you come. We're going to do a 2-day intensive workshop on sugar, sleep, and saliva and work with implementation using the continuous glucose monitor on everybody. We're going to work with the sleep set, high resolution pulse oximeter, and have the people come from there to work with that with us. And then we're going to do salivary testing on everyone and just look at those results together and learn how to interpret them and what to do with them. So on June 26th and 7th here in St. Petersburg, we're going to have a intensive workshop on sugar, sleep, and saliva, and we want to invite you all to come.
Thank you.
We've got a great room, but we can only handle about 40. And
Okay.
so
Thank you so
I,
much.
I think that will fill up pretty quickly, but we'll have that on our website
Okay.
this week, and we'll start talking about that more. But I think we're going to wrap it up, let y'all bundle up
You
wherever
bet.
you are in the cold weather throughout the country. But thank you, Bill and Debbie.
You
Thank
bet.
you so
Thank you,
much.
Laura.
And you all are the best. We just are so appreciative of you guys and love you all. And thank
Great.
you for your input into our lives. It's made so much difference. And now 100 and some more people are being influenced by your work, and we're so excited about that. So thank you,
Well, thank
thank you.
you.
And
Thank
stay
you.
warm up in Chicago, and hopefully it'll
Yeah.
thaw out in Hendersonville and you get back home in the next few days. But so we'll sign off for now. But thank you all so much.
Thanks
Have a good
again.
evening.
Appreciate
Yep.
it.
And we'll keep the ball rolling upward and onward.
Thank you.
Good
Okay.
night,
Night.
everyone. Thank you, our community. Good
Good
night.
night, everybody.